up, I'm going to turn the word over to Filip Stockmans. He is one of the people that has been innovating, that has been starting to use guide technology in orthopedics already in the early years 2000. And he has a bunch of clinical experience and search for evidence to share with us.
So I was asked to talk about guides and the use of guides within the surgery field, and I am a hand surgeon, so it will be mostly on distal radius that I will talk, because that's also a focus of ours, and it was one of the first fields in which we started to use guides. So this is what we are talking about, guides, and you might wonder when did we start using these guides? Is it new? Well, it of course started with CT scans, and there's a radiologist in the audience. So 71, EMI started with the first CT scan, which was a radar technologist from the British Army that had some spare time to figure it out how you could make a CT scan. And on the right side, you see what images you would have in the 70s. You cannot imagine that those were images that we would use for interpretation and diagnostics. Now, if you talk about visionary, this is a paper by Wilson in '86 with this type of image resolution. He was already saying, you should use this for planning, you should use this for printing, you should use this for patient-specific implants. So that was way before the resolutions that we have today. This was basically the first paper that introduced the use of surgical models in the field of hand surgery, paper out of Harvard, Jesse Jupiter, a little bit the pope of the distal radius fractures, and he introduced this technology in the early 90s. For a reference, Materialize was founded in 1990, so we are in the same ballpark. This was, of course, a single-shot type of surgery, and it was very similar to what the people were doing in craniofacial surgery, where they were doing their Leuven osteotomies and their frontal bars from Marchak by shamming that operation onto a printed skull. And this was typically something that you would do for the exceptional case. Young patient coming in with a devastated malunion, interarticular malunion, they would make a model. And please have a look at the quality of the models in the early 90s, because we are talking 25 years ago. And they were trying this surgery. And going in prepared was something that helped, because at the end of the story, this patient otherwise would have had a wrist fusion. And she got away with a reconstruction of the wrist, and maybe she will end up anyhow with arthrosis, but at least she kept function for a considerable period of time. So this is a worthwhile experience to do. My initial case of doing intra-articular osteotomies was in 2007. I started in the early 2000s by using guides for osteotomies around the thumb and for congenital cases, but this was my first intra-articular malunion, showed up basically 6 months after the injury with a consolidated intra-articular malunion. And I said, well, maybe we'll use guides to do this. Step-offs of 2 millimeters and 4.5 millimeter. Doing an osteotomy plane, which was not a plain plane, you could not do this with a chisel or with a power tool. You would need to structurally weaken along the old fracture lines and then refracture and reduce it. So basically, we were using a very old surgical principle, recreate the injury and do reconstruction afterwards. And this is what it should look like, and this is the surgery with the first guides, perforating the bone, putting in a chisel to open it up, and then reusing it just as it were a fresh fracture. This is the reduction and the fixation. 4x post-op, we are here, and this is our functional result, which is very similar to an initial fracture, a primary fracture of the distal radius that is fixed with a volar plate, would give you a similar result. So that was an eye-opener for me, that we could do things in a predictable way that we could not do before. Post-op analysis on CT scan. CT scan post-op compared with the pre-op planning, and you see that we could indeed get there where we wanted to be. This reminds me of Bob Ackland, who passed away in January of this year, who you see here on the right. This is Bob. He was a microsurgeon in Louisville, and there are people from Louisville here. He always said, if you can't see it, you can't do it. And there is a lot of virtue in bringing in these models in complex cases. On the left side, you see Jesse Jupiter from Harvard, with whom we also collaborate, as I will get back to in a little while. So what are your challenges? I mean, this is a lot about what you see is what you get. And this is something which is a thread that runs throughout this conference. It's not by pushing the button and uploading a file that what comes out is indeed what you have intended to have or what you would like to see happen. It looks great on the computer, but is it realistic surgery? Is it guide always going to fit? If you are depending on your guide, because that's your only stake that you have. Is this technology more accurate? And if you want to be more accurate, you need to know how accurate you are with conventional technology. And is the contralateral side really the gold standard that we are using, because we are always mirroring with the contralateral side? Is it realistic surgery? That means the indication is not the X-ray. You don't operate an X-ray, you operate a patient. And there is a big danger in doing this type of surgery that you get carried away by the toys, and the boys need toys. And I think that is one of the biggest dangers, that your indication should be your clinical problem, and that should be your starting point. And the planning needs to take into account a lot more than that bone, because in your segmentation you have that bone and you can flip it around, turn it around, look inside, outside and everything, but you need to get to it. And it's not always that easy to get to it. And you can't open the bone from the from the volar side and from the dorsal side, because if you do that, at the end you have a dead bone sandwich. It has to have blood. It needs to heal. And that is something that might be forgotten. And the surgeon needs to invest time in collaborating with the engineer. It is not a daycare center where you put your CT scan to the engineer and you come back in the evening to pick up your child. You need to invest time in the education of it. So is a guide going to fit? And this is a very simple example. It's quite obvious that on the left side, on the cubicle, every child can make a guide that will fit on that and with a unique position. But if you try to fit a guide on a sausage, which long bones are, forearm bones are like that, femurs are like that, it's not always that evident that you can do that. So we invested some time into that to evaluate guide fit and stability properties in the design process. There are two types of stabilities basically, and this is from the knee guide principle, but you can apply it for any guide principle. Is there rotational stability? Is there translational stability? And different guide designs, and here I take examples of the upper extremity for an ulnar osteotomy or a distal radius osteotomy and a distal femur osteotomy. Different guide designs. Can we come up with an algorithm that predicts us from the calculations of the surfaces that the guide is going to have a better or a worse fit? And you can. And it was published by Joyce van den Broek together with Jos van der Sloten. So you can get a stability score, and that stability score is something that you should take into account when you're designing a guide. And that should be something that is one of those things like a good segmentation that should be in the loop of making good guides for surgical assistance. We also did a cadaver experiment where we tried to control that, and we would do guide fit testing and automated analysis of the drill hole positions and osteotomy planes, because that's what you're going to do. We looked for positional error in the XY direction and in the XZ plane and the YZ plane for the classical osteotomies. 9 drill holes, 1 osteotomy plane in each cadaver, and if you look at the average, you see that you can get accurate results, and that a good guide will give you an accurate positioning because you are below the millimeter margin to see your drill holes in the right position. For the osteotomy planes, you come in the same ballpark. This is the accuracy that you really look for. Is this technology more accurate? What is conventional technology? Conventional technology is using a fluoroscopy arm, taking the contralateral side, using K-wires to indicate your planes, and do your osteotomy by basically eyeballing. And do get doctors good at it? Yeah, I mean, if you have experience, you get pretty good at it. This is a paper coming out of Balchrist in Switzerland, and they looked at 15 corrective osteotomies where they did a so-called 3D analysis, but it was not a mimics style analysis, it was more by using biplanar radiographs. And instead of doing the eyeballing, they would print basically the piece that would need, or the gap filler for the osteotomy. So that was, instead of the surgical guide, that was their template to get to the right positioning of their osteotomy. And the treatment goal was restoration of angular deformity within 5 degrees and only variance within 2 millimeters, extra-articular osteotomies of the distal radius. Result, 40% met their criteria. That was far lower than they would expect. And if you would use the conventional technique with the one from Diego Fernandez with the K-wires, you will have even less than that. We looked at the accuracy of clinical cases where patients had a combined intra and extra-articular malunion, so the absolute worst case scenario. And we compared between the pre-op virtual planning and the post-op CT scan. So both measurements were done in the three-dimensional environment, not on biplanar X-rays. If you look at the results, you see that on average, the extra-articular osteotomy is way better corrected, except for the volar tilt. So in these extreme conditions, you can still have a very accurate reconstruction. If you look at the intra-articular reconstruction, where we looked at gap formation and at step-off, you see that we can get a very reliable intra-articular correction within the 1.5 millimeter range, which is the accepted range for intra-articular step-off and gaps. So it does work. We can do it. And bad people say that a politician in the United States used this quote to make a campaign. But is this enough? We currently reconstruct the contralateral side, the contralateral shape, and we assume it will function. This means that the contralateral side should be the standard. But reaching that standard, will it give back motion? Because the patient is not looking for a perfectly matched radius. The patient is looking for pain relief. Patient is looking for function. Paper out of Amsterdam where they compared bilateral radius and ulna to see what the bilateral symmetry was in the 3 planes. And there is a linear symmetry between left and right radius, and it is fairly close. The only problem is that there are length differences, and we all know that. We all know that not all of our arms are equal in length. If we put on a suit or a jacket, or you have your pants shortened in the shop, many of us will have, well, this one is a little smaller, this one is a little longer. But the good thing about that length is that radius and ulna have a good covariance. So you can, if you have an ulna which is intact on the contralateral side, you can use that to template to rescale your radius. Is that also true for volar tilt and radial inclination? Yes. Is that true for radial torsion? No. And radial torsion angle is a very important parameter in patients that have prosupination problems, people that have a problem in rotating their arm. And is this disabling? Yes, this is very disabling. Because if you have a pronation problem, you can flail out. This is not very polite at a table if you're squeezed in a banquet. But if you have a supination problem, you need to shift all the way around because your body is in the way. And you can't put a dish on the table. The soup will go, in the nap of the person that should eat it. So those are very important problems. And we don't have a good alternative at this moment. And if was this known? This was known. Frederik Schwind from Brussels, when he was at the Mayo Clinic, he looked at a larger population database, and he said, well, basically population-based standards are as good as contralateral. Is this important? Yes, this is important. And I will show you why. This was a patient that walked into the office, 36-year-old, 5 months post-injury, fell from his truck, had a devastating distal radius fracture, was treated, but he had 35 degrees of dorsal tilt and 15 millimeters of shortening. Now, this is a fairly simple interarticular problem. Interarticular, you don't need to do anything, but extraarticular, there is a gross deformation. And he had no function, and he had a lot of pain. So we did the classical thing, took the contralateral side, mirrored it, rescaled it, which means shortening, and this is the deformation. So we plated it, reverse engineered it, only had distal screws because the fragment was very small, made a guide, and went to surgery. Did the osteotomy, which was a straightforward osteotomy. Here you have the extended radial approach where you really need to release soft tissues because you need to correct for a long shot. And this is the position of the plate in the malunion. Now that plate, this part, needs to get aligned, and let me see that. This plate needs to be aligned with that radius. So there's a long shot to go. And did we get there? Yes, I got there with a lot of, force and patience and stuff like that. I got there, and I grafted it, and this is the Postop X Ray, and I was very happy. And then the S word comes. This is post-op. This is 4 weeks. The plate is straightening. If a plate is straightening, it's going to break. And this is 8 weeks. It's even more straight. And then it happened. And then we were back to square zero. So I took him back, got on the new plate, and I neutralized it by an X-fix. Now, I can of course say, and you will see a picture of the patient, he was non-compliant. And he had everything to be non-compliant. He was a trucker, he was male, he was smoking, he had tattoos, and he was drunk when he fell from his truck. So I could, wonderful excuse. Yeah. So here we are 20 months post-op, it's healed meanwhile, and his function is okay. But did I really need to go all the way for the 15 millimeters? Maybe I could have gotten away with 12 millimeters, and life would have been so much easier. With no revision surgery, no external fixator, we don't know. So this is why we are here. We want to create evidence. So why do we want to make evidence? Because there's an academic argument. We are convinced that it is better. And somebody needs to pick up the bill. And he says, well, this is going to cost extra, so give me the proof. That's why we are here. So that's why we set out a prospective randomized trial. We did that RCT thing, the holy grail. So we said we are going to go for something simple, extraarticular osteotomies, fairly, homogeneous patient group. We will do this in a multi-center way, Harvard, ourselves, University of Louisville, Kleinert-Koets, and Gothenburg University. Experienced surgeons. The comparator would be conventional osteotomies. We would do the classical examinations, clinical, functional examinations. We would do patient-rated outcomes, which we would take as primary parameters, and we would go for about 30 patients. So we are no longer including, but we already have a little bit of the initial results, which means that we have currently 16 out of 30 patients that are evaluated. 9 were guided, 7 were non-guided. And it was done in the SurgiCase platform. So this is the conventional technique, and this would be the planning where you would have indeed that nice step-off that you could recreate, and that you see here that you really can recreate that step-off, which is harder to do with conventional technique. And that's the result post-op. If you look at the results, you see operative time is shorter with guides. Fluoroscopy time is dramatically shorter when you use guides because you don't need to eyeball all the time. You see some extensor tendon irritations, which are due to the perforating screws, usually on a volar plate, and one case of CRPS. Now, that one case of CRPS can be like the trucker, where we really went, if you see this case, this is also a long lengthening, this has a risk of creating CRPS, complex regional pain syndrome, which is a considerable complication, but this is because we want to reach the gold standard. So this is something that plays in that ball game. If you look at the scores, pain scores and satisfaction go hand in hand. We are lengthening probably more in the computer-assisted group. DASH scores and PRWE, which are functional scores, they're going to be the same. So I bet the end story is going to be that we are going to see very little difference in functional scores. There will be a difference in the anatomy of the reconstruction. That's probably going to be the end point of that research. So let's go back. On top of the pyramid, you have systemic review of randomized controlled trials. Not one of these trials, but multiple trials. Let's take a little step backwards. Let's take a look at distal radius fractures. The most frequent fracture to be seen in the ER. Massive amount of patients. Massive amount of impact on society. So let's see. These smart people from the AOS, they put a whole committee together to make recommendations. They read, I mean, you can go, there is another paper that is in the Cochrane database, and I mean, there are several papers about this. This is about guidelines. So they ranked the evidence and they asked 29 questions, and I'm not going into the detail, but basically they ranked the evidence that they had. There is consensus, there is moderate evidence, there is weak evidence, and there is inconclusive is a posh word to say we don't know. 14 inconclusive, half of the relevant questions they asked. There are 3 questions they asked in consensus. So they had consensus agreement on 3 questions. I will show you. If you're not operated, it's probably good that if you're in a cast that you go back to have a check. Makes sense. If you have pain, it's a good idea to go and see a doctor. What basically they say, maybe your cast is too tight and you might have CRPS. And it's a good idea to move your fingers. This is the evidence, and this is, I mean, the first randomized controlled trial that was put out on distal radius fracture was done by Jesse Jupiter on Norian, a synthetic bone graft. It was the first randomized trial. It was the first of a long series of randomized trials that proved that we could not prove difference. Why? Maybe we are not looking at the appropriate parameters. Maybe there is something else that is in the ballpark, but it is very hard to prove things with RCTs. And with that, I will conclude.